Our next speaker is Dr. Sharlay Butler, and she will be speaking on updates in sexually transmitted infections and special clinical situations. Dr. Butler is an academic specialist at Brigham and Women's Hospital and an associate program director for the Mass General Brigham OBGYN residency program. She's fellowship trained in reproductive infectious disease and holds her master's in public health from the University of Pittsburgh. Her research interests are in implementation science as it pertains to sexually transmitted infections and HIV prevention and treatment, medical education, and community-informed healthcare delivery. Dr. Butler.
Thank you very much for that lovely introduction. Hello and good morning, everyone. These slides are up to date as of the last iteration of the STI guidelines from the CDC, and we'll go through everything. Can I advance my slide? There we go. Okay, a few disclosures. I have no financial disclosures. There is gendered language here. This presentation does not represent the full spectrum of gender identities that are there, and I want to acknowledge the impact of COVID-19 on STI data. There were variations in diagnosis and interruptions in reporting of STIs, and so all data that was surveillance data from 2019 or during pandemic, height of pandemic years, is interpreted very cautiously. Here are our learning objectives today, 3 succinct ones, and the source that I'd like to highlight for everyone is the STI treatment guidelines from the CDC. They are restored and up to date, but this is a nice point of care option that you can access on your computer. It is also available as an app that you can reference, and it has all of the infections and treatment recommendations there and available. So, as you may know, the CDC guidelines were recently updated in 2021, and here is a focused summary of the relevant updates for this lecture that we're going to cover. And so the main updates that occurred was the switch from STD, so disease, to STI, infection, but importantly, screening recommendations, so special population recommendations, and that includes pregnant women, adolescents, children, men who have sex with men, women who have sex with women, transgender and gender diverse folks, and persons in correctional facilities. And then 3-site testing, so oropharyngeal, cervical, vaginal, and rectal swab testing. And then updated information about syphilis, which is on the rise, and hepatitis screening, particularly in pregnancy. Updated treatment regimens for gonorrhea, chlamydia, trichomonas, and PID, pelvic inflammatory disease, and then some reframing of guidance for HIV prevention, HIV PrEP, pre-exposure, and PEP, post-exposure prophylaxis. So for the purpose of this lecture, we'll review the following of infections: gonorrhea, chlamydia, PID, trichomonas, and syphilis. And then we'll end with some special circumstances: syphilis in pregnancy, resistant trich, and HIV PrEP. And again, this is not an exhaustive lecture because each of these infections could be a lecture in and of themselves. We're just going to highlight what the guidelines have been updated with as it pertains to these infections. And so specifically, I'm not going to cover herpes, HSV, HPV, or specifics of HIV infection. There you go. All right. Okay, so a little epidemiology. Overall, in 2022, and that is the most recent surveillance data that we have for STIs in the US, there were over 2.5 million cases of syphilis, gonorrhea, and chlamydia in the US. And while the exact numbers aren't important, it's important to understand the relative rates and trends among STIs like these. And so, my computer, there we go. And so when compared to 2018, which was the last sort of composite update of data, the rate of chlamydia has seen a small decrease in cases, but gonorrhea and syphilis have steadily been on the rise, and there's been over, 640 million cases of gonorrhea. And the most alarming concerns really center around the syphilis epidemic. And syphilis cases, which include all stages of syphilis and congenital syphilis, have risen over 80% since 2018. Remember, primary and secondary syphilis, these are the most infectious stages of the disease, have steadily been on the rise in the US after really reaching historic lows in the early 2000s. And so since 2018, there's been a 68% increase in cases and a 10% increase increase in cases just from in 2022 alone. Consequently, as the rates of syphilis have increased among childbearing persons, the rates of congenital syphilis have also increased. And this slide is showing that relationship. So congenital syphilis occurs when a mom or a mother is infected with syphilis and transmits that infection to her fetus during pregnancy. And congenital syphilis can cause severe illness, miscarriage, stillbirth, and early infant death. And over the past 10 years, there's been over a 900%, so 937% increase in congenital syphilis cases. That's nearly a 31% increase from just 2021 to 2022. So steep increases in cases that we're seeing in the US. Let's talk about the economic burden of STI treatment and management, and it's enormous. It's estimated to be around $16 billion in direct medical costs when you account for acute and long-term health consequences. Chlamydia, gonorrhea, and syphilis combined account for about $1.1 billion in direct medical costs, and the care for young people, and so that's age 15 to 24, accounted for about 60% of those costs. And so this graphic shows that care of women represented nearly about 75% of all STI-related direct lifetime medical costs. We're not including HIV care in that. You can see on this diagram here, no pointer there, towards the end that HIV makes up a significant portion of direct medical costs, so we've excluded that from here. In fact, when we look at age and STIs, young men and women account for almost half of all new STIs and make up half of all cases of gonorrhea, chlamydia, and syphilis specifically. And so really the take-home point here is that sexually active young women, specifically those 15 to 24, should be screened for STIs annually, really regardless of symptoms when we think about this from an epidemiologic standpoint. As alluded to by the economic share that women represent in STI care, women are disproportionately impacted by STIs, and this is reflected in the rates of chlamydia. One driving force behind this is that chlamydia infections in women are usually asymptomatic, and screening is necessary to identify most infections. As a result, routine chlamydia screening for sexually active young women, again, has been recommended by the CDC since the early 1990s. Racial disparities exist in terms of STI rates, outcomes, and the higher prevalence is linked to social networks, access to care, stigma, discrimination, all of the things that are well known and documented. But I want to spend a moment talking about how that is further parsed out when we think about sexual network and partner selection and STI relationships. So in addition to demographic factors and behaviors, it's important to consider sexual networks and their configuration as contributors to risk of STI acquisition and transmission. And networks really help explain why individuals can have the same risk factors, and yet one may have a much greater risk of contracting or transmitting an STI. So in sexual networks, partners may select one another within groups such as age, ethnicity, class, religion, or other characteristics. However, partnering can be random and/or anonymous, and this type of partner selection in forming a sexual network in part explains racial differences in STI rates. And the configuration of these partnerships is what's called a sexual network. And so that's, again, the groups of persons who are connected to one another sexually. The number of persons in a network, how central the high-risk persons are within it can all influence transmission rates. And then the percentage of folks who are in monogamous relationships and the number of links each one has to each other, those all determine how quickly STIs can spread throughout a network. Let's talk briefly about mechanism of transmission because it's important when we think of STI screening, and it underpins why we now recommend 3-site testing. The sexual transmission of infections can classically be thought of being transmitted via vaginally and or anally. They can be transmitted via pathogen contact with the oropharyngeal mucosa. And then perinatal transmission of STIs can happen transplacentally or transvaginally, and depending on the specific pathogen, as we'll see on this next slide. So when we think of perinatal transmission of STIs, generally those are the torch infections and ascending bacterial infections like PID. Pathogens might invade by several routes, and these routes can vary depending on the gestational age. And so I've listed some of the common infections there, and I've highlighted PID in red, and I just want to make a little quick note on that. So PID during pregnancy is actually rare, and the exact pathogenesis isn't known, but it's important. So theoretically, PID can be the result, again, of an ascending infection, since the mucus plug and decidua don't seal off the uterus from ascending infections till about 12 weeks. After that, there's other proposed mechanism of actions like hematogenous spread, lymphatic spread, local spread from adjacent affected organs like the bowel, but important to remember that PID can still be detected in pregnancy. Gestational age is a factor to consider if that is on your differential. Next, so this is the meat of updates from the CDC, particularly as it pertains to treatment. And we're going to start off with chlamydia and gonorrhea. So the classic signs and symptoms of gonorrhea and chlamydia first include urethritis, so dysuria. You might get a UA that shows pyuria without bacteria, cervicitis. So it could be asymptomatic. You can see things like mucopurulent discharge, or even like a friable, easily bleeding cervix. PID, so that ascending infection, abdominal pain, adnexal tenderness. If it is continues to progress, a perihepatitis, so that Fitzhugh-Curtis syndrome, right upper quadrant pain. It's a capsular infection, or a symptom of capsular distension, so you're not going to have sort of LFT elevation because it's not an intrinsic liver issue. And then really, what also comes up is sort of like Bartholin glands and vulvar cysts. The only real STI relation between a Bartholin gland or a vulvar abscess is actually Bartholin gland infections or Bartholinitis. Gonorrhea specifically has been identified from infected Bartholin gland cysts. And so that's just a classic picture of your enlarged, inflamed, infected Bartholin gland. So for women with urogenital chlamydia infection, this is diagnosed either by vaginal or cervical swabs or by first void urine. Cytology specimens from pap smears can be acceptable, but the test sensitivity using these specimens is probably lower than a cervical or vaginal swab. NATs are the most sensitive tests, so the swabs, and they allowed for the widest variety of FDA-cleared specimen site testing, specifically rectal and oropharyngeal. It is the preferred test. There's lots of other testing modalities that I've included here for completeness sake, but they often need specialized labs to process these types and so aren't widely used. Self-collection of swabs, again, are highly acceptable and appropriate for patients. And there's good data to show that self-collection of vaginal and rectal samples perform at least as well as provider-collected samples. And so the CDC recommends site exposure, which is considered pharyngeal, oral, and rectal. So really asking people how and where they are having intercourse or sexual relationships. So specific updates to the treatment of chlamydia. Why did this happen? Like azithro was a great drug. Well, in 2021, the recommendations changed because there was a growing body of evidence that determined doxy was actually more efficacious in treating urogenital and rectal chlamydia in men and women. Most notably, doxy was even better at curing rectal chlamydia. And so this is particularly important because for women who have urogenital chlamydia, up to 83% of them actually have a concurrent rectal infection. So even in women who did not report having receptive anal sex, were testing positive for rectal chlamydia. And so what this suggested is that women with repeat urogenital chlamydia were probably just being auto-inoculated from inadequately treated infections from the rectum, and thus playing a factor in continued transmission. And so with that, that was the main impetus behind changing from primarily single-dose azithromycin to doxycycline. In regards to oropharyngeal chlamydia, the clinical significance of this is unclear. The prevalence is probably low, probably due to under-testing, and actually most chlamydial throat infections are asymptomatic. But it can be spread to genital sites, so testing is recommended for folks who endorse oral genital sex. And while the evidence is still limited, the observational data that we do have suggests that doxy is probably more efficacious in treating throat infections than azithro. So treatment regimens, doxycycline, 100 milligrams twice over 7 days. There's some alternative recommendations here. In pregnancy, azithro is still the recommendation. And then there is emerging data on the value of doxycycline as post-exposure prophylaxis. These are ongoing studies in women or people who have receptive vaginal sex. But I suspect in the next couple years there'll be recommendations about taking post-exposure doxycycline within 24 to 72 hours to prevent STI transmission. So updates to gonorrhea treatment specifically. So dual therapy is recommended still if chlamydia has not been excluded, and this is just based on that they're very common co-pathogens. First-line treatment is now weight-based and can be used for all site infections. For patients that are penicillin allergic, the treatment is still with a third-generation cephalosporin, like ceftriaxone. And there are alternative regimens that I've listed here, but the big change, again, for gonorrhea treatment is that we are now doing weight-based dosing. So whether or not somebody is over 150 kilograms, doing either 500 milligrams IM or a full gram. Now let's transition to talking about PID outside of pregnancy. So PID is an infection of the upper genital tract. It can be secondary to STIs such as gonorrhea, chlamydia, but also, and probably more likely, is polymicrobial. And so it's an ascending infection, meaning that it's an infection from the lower genital tract, the vagina and cervix. It causes infection, spreads upward by any combo of endometritis, salpingitis, tubo-ovarian abscesses, and pelvic peritonitis. And recognizing PID is important because of the long-term sequelae in terms of chronic pain and infertility, and in extreme cases, infection refractory to IV therapy, which results in a hysterectomy and BSO, which is shown here. My slides disappeared. There we go. Okay, so remember that PID is a clinical diagnosis. There's variable signs and symptoms of PID making the diagnosis difficult. And really there's no constellation of history and physical or lab findings that are both sensitive and specific. So in general, one or more of these exam findings can be used to diagnose PID, and that's cervical motion tenderness, uterine tenderness, adnexal tenderness. And one or more of the following additional criteria can be used to enhance the specificity of the minimum clinical criteria to support your PID diagnosis. And these include a temperature, so true temperature 101, mucopurulent discharge, cervical friability, or lots of white blood cells on your wet prep if that's what you're doing. And then of course, known gonorrhea and chlamydia infections. There are, imaging, surgery, and biopsies have a limited role in diagnosing PID. Again, this is mostly a clinical diagnosis. So what are the updates? The evidence that spurred changes or recommendations in treatment changes was due to the mounting data about the role of anaerobic bacteria, specifically Bacillus B. fragilis, causing tubal and epithelial destruction. So in the guidelines now universally include Flagyl, which has great anaerobic coverage and abscess penetration, as part of the existing regimen in hopes of preventing those long-term sequelae of this damage. So infertility, ectopic pregnancies. Remember the economic impact of these long-term sequelae on direct medical costs. And so so I've included here are some options: ceftriaxone, again weight-based dosing, versus IV ceftriaxone. The doxy, and then here Flagyl. And then I've included Rex for cefoxidoxy or cefatitenin doxy, not that those have changed, but I add them here as a reminder to say that you do not need to add Flagyl to those regimens because cefatitenin and cefoxitin already have great anaerobic coverage. So really the change is adding Flagyl to the recommended treatment if you're using ceftriaxone, and then also adding it to your outpatient transition to oral therapy. So trichomonas. Trichomonas, again, part of the workup for vaginitis. It's a frothy yellow-green vaginal discharge. Folks will complain of vulvar irritation. Untreated infections can last months to years, so people can really have a persistent infection with trichomonas. Classically, strawberry-appearing cervix, so these like erythematous punctuate lesions. Postcoital bleeding is an often common complaint, and then up to 85% of these infections actually have minimal or no genital symptoms. In terms of screening and diagnosis, there really isn't, no recommendations are available for sort of general screening. There are recommendations if someone is living with HIV to screen annually for this. 3-site testing is not specifically recommended. There's not a whole lot of data on extra general sites of infection for TRIC. Mostly you should consider screening and treating if anybody is presenting and asking for STI treatment or has other risk factors for contracting an STI. So the sample type that's recommended is the endocervic, a vaginal or a urine sample. And there's lots of different test types. Very classically, we're taught about wet mounts. And so I've included here what a mobile flagellated organism may look like under microscopy. Microscopy is not always sensitive up to 80, not a perfect test. And it is really important to get that sample under the microscope quickly because sensitivity decreases the longer that sample dries and is outside of the body. pH isn't super sensitive. Culture is the gold standard to diagnose TRIC, but not widely available. NATs are really good. You can use them on a variety of samples, so cervix, vagina, and urine. And the benefit here is you can also have people self-swab, which is really nice. And then there are other point of care testings, tests that are coming to market, but again, aren't super sensitive specific, widely available. And then pap smear, just a note, is not a great way to diagnose tricks. You should follow up a pap smear reading of trick with some sort of testing. And then, lastly, when it comes to, and this is what trick looks like on a still frame of microscopy. And so updates to treatment, the recommendations are now metronidazole or Flagyl BID for 7 days. And this is based off of a meta-analysis of randomized control trial data that demonstrates multi-dose regimen, reduced test of cure positivity at 1 month by 50%. Metronidazole gel, importantly, is not recommended for treating trichomonas infections because it doesn't get really great penetration into the urethra and perivaginal glands. There are alternatives. Metronidazole, 2 grams in a single dose is still a valid option, especially if you have adherence concerns for folks. And then tenadazole, 2 grams orally once. Follow-up 3 months after treatment, and then expedited partner therapy is encouraged and permitted in most of the United States. Now, syphilis. So I'm going to spend the bulk of the remaining time we have on syphilis, and the CDC and this portion of this talk really is reflecting the increase in syphilis cases across the United States, and so it's pertinent at this time to really just refresh ourselves on like what syphilis is, what's the treatment, and how to think about it during pregnancy too. So syphilis can occur in multiple stages. Primary syphilis classically is thought as that chancre, that painless chancre, but remember it could be multiple chancres, and that it can resolve on its own, 3 to 6 weeks later without any treatment. So people may not even know that they have primary syphilis depending on where the chancre is. Classically, we are taught that the chancre is on the vulva, but remember, the chancre is going to happen wherever the pathogen load hits, wherever it comes into contact with mucosa that it can infect. So it can infect hair-bearing areas. This is sort of the classical chancre on a mucosal surface of the vulva. This isn't, it's hard to see, but aren't a lot of pictures, but you can have cervical chancres, so sort of this erosive area on the cervix that's friable. Or you can have chancres on your lips. But remember, the chancre is gonna be where the pathogen encounters, so it's not always on the vulva. Then we have secondary syphilis. This is classically that maculopapular rash that also can involve the hands and feet, may have some lymphadenopathy. And then remember, primary and secondary syphilis are the most infectious stages of syphilis. Next is what a significant portion, particularly women who aren't presenting with that classic vulvar chancre or maybe a rash do, is that diagnosis of syphilis that you get because you just did syphilis testing or screening. So this is the asymptomatic or latent phase of syphilis. And again, asymptomatic. And when we have this stage, we want to think of, is this an early latent or a late latent infection? And the way that you're going to distinguish that is, do we think this infection occurred within the last year or not? And so that comes from history taking, that comes from looking at prior syphilis testing to see if there was positives, negatives, and really helping to narrow that down. And that's important, one, because of treatment indications. This is 1 versus 3 doses of penicillin. And it also has some implications on pregnancy, as late latent can be, though it's not highly contagious, still can be transmittable perinatally. So important to help narrow down and distinguish between those two. You can always call the Department of Public Health in the county that patient is in or was in, and because syphilis is a reportable disease, they should have records of anybody who has tested positive and received treatment, and that can be a nice help. And then lastly, tertiary syphilis, which thankfully we do not see often, but anybody who has multisystemic symptoms should be referred to ID, and remember this can develop slowly over time, 10 to 30 years after your primary infection. Making sense of testing. Syphilis testing is confusing, and there's multiple test measures that measure different types of things, and this, I think, is the most important part of syphilis, now that we're seeing it so much. And some of this depends on your institution-specific protocols, but I'm just gonna review the testing really quick because it'll help with some of the cases we'll do later. And this is non-exhaustive, it's a very simplified overview of this. But remember, there are two types of tests. So there is your RPR, your VDRL. Most people in the US use RPR. Other countries, the VDRL may be a little bit cheaper, but that is still an antibody test. And then there's the treponemal specific. Both of them are antibody tests. But one is going to be really specific for the treponema, the T pallidum, and the other one is going to be less specific. So which is which? When you think of the less specific one, so the RPRs, the titers, and this is why sometimes you can get sort of false positives. It's because it's detecting a lipoidal antibody, and that lipoidal antigen is found on lots of different body tissues. So it can give you a false positive because it can be on, you can find that antigen on different tissues in the body. Okay? As opposed to the treponemal specific ones, those ones you're only gonna find on spirochetes, on T pallidum. Okay? And so those ones, the benefit there is that it is more specific to the actual treponeme, but this one's gonna be positive for the rest of their life. So remember, you're gonna need both of these tests to sort of interpret what stage of syphilis this person is in. Okay? And so this is just highlighting that the antigens and where they are and what they're specific to. The benefit of some of these tests and which one your institution uses, again, is sort of based off of lab culture, costs. Titers are cheap and they're easy to use, but automated tests like treponemal specific things, you can run a whole bunch of them. And so there's value of in each and downsides of others. Interpretation. Key points. Again, this is not exhaustive. I've tried to boil it down just to this is sort of what I need to at least know to interpret my testing. And then with this, I hope that all of the very convoluted algorithms that are out there, on the CDC and ACOG, can be a little more interpretable. So which test to use first depends on your lab, but remember, whatever test you use first, you have to have both to make a diagnosis. For the non-treponemals, these are quantitative tests. So these are your titers, RPR, VDRL. This is called a traditional screening sequence, but most people just know that you need an RPR. They're gonna measure the amount of antibody, which is gonna correlate with the amount of infection there, or the activity of infection. And then the titers, again, are, they're titers. They're gonna go up, but you should expect, except for a few cases or a small subset of people who sort of never clear those titers, the titers should go down and clear with treatment or time. And the other one, so TPPA, FTA, ABS, These are all types of EIAs, CIAs. So there's that treponema-specific test, and then the EIA, CIA, all that means is that it's just, now you're just doing mass numbers of TPPAs. But the TPPA is actually the test that looks for the treponema, and then you can decide to run it as a single test or a whole bunch at the same time. But that combination, alphabet soup, is a qualitative test. It's either gonna be positive or not, because it's gonna tell you if that person has had the T. pallidum spirochete in their blood and has formed a reaction to it. And they're gonna remain positive for the rest of their life. So based off of the results of those tests, then you can sort of go down these nice algorithms and determine what stage of syphilis somebody is in. Treatment for primary and secondary syphilis is 1 dose of penicillin. If someone is allergic and not pregnant, doxy, tetracyclines can sometimes be used. If they are pregnant, penicillin is the only antibiotic that is effective in treating congenital syphilis, so that's why we use it, and the only one that's really studied, so desensitization is the only option for pregnant folks. And for latent syphilis, early latent, late latent, depending on which stage they're in, different dose regimens of penicillin. The important thing to know here is that there is not as much forgiveness between the interval of penicillin dosing if somebody is pregnant. So it's supposed to be every 7 days. You can kind of sort of push it out to maybe 10 to 14 days if somebody's not pregnant. That interval is less forgiving for pregnant folks, and if they've gone more than 9 days between doses, the sequence should be repeated. Okay. And then again, if we'll go through signs of failure, but if someone's not getting better, if they're showing neurologic symptoms, they need to refer to ID because their cerebrospinal fluid is going to need to be examined. So tertiary syphilis, we're not going to talk about and go into details, but know that it's a different type of penicillin, and that's important because our IM penicillin is not going to treat anything that's in the central nervous system. So neurologic symptoms, think tertiary syphilis, get them over to ID. This is a very, very brief, non-exhaustive summary of sort of what to expect for treatment response and follow-up. I won't go through this. It should be in your syllabus, to look at. But the important thing here is that to highlight is in terms of follow-up, know that these folks who test positive are gonna need at least 6 months and 12-month follow-up, so repeat titers, and then depending on the stage, may even need to be followed 2 years out. So if you're treating somebody in pregnancy, we've got a short window to do it, and it's important to communicate that to them that they're still gonna need ongoing follow-up. As far as expected response, it's actually not your 4-fold decrease. It actually doesn't occur until much later. Up to 6 months and even 12 months is when you can really expect your 4-fold decrease to happen, which can be disconcerting for us because we often don't have that time with those patients. But no, if there's not a 4-fold decrease, that's not necessarily a sign that treatment has failed. I have more on this in just 1 sec. And then management of sexual partners. Essentially, the most important thing is that regardless of what stage the index patient sort of is, you have to decide whether or not to treat their partner based off of when the last sexual encounter was within 90 days, so 3 months. If they're within 3 months, then they essentially qualify for expedited partner therapy. So treatment failure. There's no definitive criteria for treatment failure by serologic testing, but there's some helpful guidance on when to suspect treatment failure. And it can be generally thought of when signs or symptoms persist, as well as those with an increase in titers. So not a decrease, but an increase in titers. Titers should never increase if you are treating syphilis. And so these patients, this is either going to reflect a reinfection or somebody, again, who's experienced treatment failure. And it's important to know that, you can always err on the earlier side of things. 12 months is like sort of the time frame you would expect or could give somebody to show titer decrease, but it's also okay at 6 months to check in, especially if this person has ongoing risk factors, to reassess for signs of treatment failure and consider retreatment. If you suspect treatment failure, you want to perform an HIV test. You want to, because that's immunocompromised, less likely to respond to treatment. You want to rule out reinfection. You want to make sure that this is not tertiary syphilis. And then, again, reassess if you want to treat with 3 doses of penicillin. So the last little bit we'll spend on special considerations, and that is treatment and post-treatment follow-up in pregnancy. This is a lot of information. It's in your syllabus, but I think the things that you want to highlight here is that because syphilis is on the rise, because congenital syphilis is on the rise, you want to screen people at the beginning of pregnancy, sometime between 28 and 32 weeks, and then at delivery. More frequently if this person is having signs, symptoms, or recurrent risk factors. In terms of treatment, again, really important to sort of narrow down through history and physical when time of infection could have occurred. Do a good exam, check the mouth, look at the cervix, look at the vagina, look at all places where pathogen load can encounter for pregnant folks. And then you want to determine treatment and make sure they know that it is penicillin and arrange desensitization if you need to. In terms of different monitoring types, there's lots of guidance out there. What we do, there we go. What I've laid out here is sort of what we do at the Brigham. So pre-treatment titers around 3 months after treatment. Sometimes it lines up with that 28 to 32 week timing, sometimes it doesn't. And then sort of 6 months later. The key thing you want is that if you're not gonna have somebody captured for that entire time in your prenatal or gyne care, that they know that they still need surveillance, serological surveillance after they leave your sphere of care. The CDC has much more simplified titer guidelines, and that's based on whether somebody's infected before or after 24 weeks. But I think the key thing to take away is just knowing that these folks need to be followed likely outside of pregnancy. And then in terms of different things to do during pregnancy, adding on a 3rd trimester ultrasound, so you're looking for signs of congenital syphilis, MCA Dopplers to look for fetal anemia, hepatomegaly, placentomegaly, all of those things. Those things should improve with treatment. And here I've listed sort of the order that things improve upon. Here, the risk of congenital syphilis, basically the further along in gestation that you are in and contract syphilis, the higher risk of congenital syphilis. And so here's some counseling points down here. And then in terms of delivery planning, really there's no change in recommendations to deliver unless congenital syphilis signs on ultrasound findings are worsening and it would benefit the fetus. There aren't any intrapartum things that you need to change, so they can still get an FSE, still get an IUPC, and then in terms of what to do after, you want to send the placenta down to pathology, note maternal stage of treatment, and you want to make sure PEDS is aware because that's going to have implications on babies testing, treatment, and follow-up. So that is congenital and syphilis and pregnancy, syphilis and pregnancy in a nutshell. The other special consideration that I'll go through is resistant trichomonas. Again, this is anybody who's not responding to traditional treatment despite, and it doesn't have any re-exposure risk. Here is a list of different treatment options. I won't take credit for these treatment options. There's a wonderful, wonderful group of folks at UAB CDC, who have an ID vaginitis clinic, and through Professional Society, we've shared these sort of tried and true recommendations. But don't fear, you always have backup at the CDC. You can contact them, fill out a form of your concern for resistant trick. They will mail you a kit. That kit can be collected then. It's just a swab sent back to the CDC, and they will run the resistance testings. But that's the only way that you can actually confirm that this person has a resistant infection, is through that testing. In terms of HIV PrEP guideline updates, there are now 3 different pharmacologic ways to take PrEP. The only one that is approved for folks who are assigned female at birth or have receptive vaginal sex is Truvada or emtricitabine, tenofovir. And so it is a once daily pill. And the key thing for us in our sphere of practice is that it is safe in pregnancy. There's no increased risk of teratogenicity. That's tracked very closely. And that the postpartum period is actually a heightened risk of HIV acquisition. And so for folks who have risk factors for acquisition, starting PrEP during that period is very safe. And then, for lactation, minimal drug transfer, safe for lactation as well. And so HIV, there are whole specialties dedicated to this treatment, but if you have questions, if you want to look up recommendations for perinatal HIV infection or management, prevention, those type of things, the HIV.gov website is a really nice place where all of those recommendations are kept. Okay, and I will stop there and take questions. Thank you so much for your time and attention.
Thank you, Shar. Just a note on time so that nobody's worried. We will break to give everybody a 10-minute coffee break, and we will start the next talk a couple minutes later. So please don't panic about not being able to get up. You have a lot of questions coming in from the chats. Some of them I also just want to acknowledge, Dr. Butler will be part of the first panel OB discussion. So a couple of these questions I'm going to table for the group discussion at 11. But I would like to pose a question about a provider who writes that the majority of PID she sees is actually in postmenopausal women with diabetes and obesity who are gonorrhea chlamydia negative, and it's diagnosed clinically. And usually there's imaging to suggest a pelvic abscess. Given this patient's different than classic teaching, how do you recommend changing the treatment? Or do you recommend changing the treatment?
I don't recommend changing the treatment. I think that scenario actually highlights that there is a lot more we know about the actual microbial milieu of the lower and upper genital tract, and that PID is a polymicrobial infection. And so we have a whole array of bacteria in our vagina sort of naturally, lactobacillus predominant, and any ascension of bacteria into the upper genital tract, which is not sterile, can cause an infection. So I think that scenario just highlights that this is more a polymicrobial infection rather than a classic STI infection. So it can sort of live in both worlds.
Great. And then a couple questions just going back to a comment about trichomonas specifically, if it comes back positive on a pap smear. Which STIs should we be treating based off the pap, and which should we be asking to come back for further testing? And another sort of second piece to that question, if the patient's not able to come back, would you favor treating anyway?
That's a great question. So for trick specifically, if it comes back on the pap smear, that's somebody, if they're able to, I would ask to come back and do a NAT, either cervical vaginal swab or a urine dip. If they're unable to come back, PAP is not a perfect test, but I think that's when you take that clinical situation in context, and if they are somebody who is adherence concerns and has risk factors for a trichomonas or STI infection, I think erring on the side of treatment is totally reasonable. In terms of which STIs to treat based off of your PAP, gonorrhea, chlamydia are fairly reliable. I didn't review this, but genital herpes is something that you can have a continued discussion with people about. But those are ones have fairly good sensitivity and specificity off of the PAP smear.
Great. Thank you. And then we will talk about syphilis in a little more detail during the case discussions at 11. But are you able to explain how we can determine a new infection versus a recurrent or an old previously treated infection for syphilis?
Yeah, this is a little bit of sleuthing and a little bit of repeat testing is going to be the key to determining those things. In terms of the first thing you want to do is make sure that I would check with the public health department, see if there has been any reported treatment, because that's going to sort of help you get baseline serological tests, and then repeating titers, every 2 to 4 weeks. And again, treated syphilis is never going to have rising titers if it's adequately treated. So if things are increasing, that's a sign that this is probably either an untreated or inadequately treated infection or a new infection, reinfection.
Excellent. And 2 last questions. One, do you routinely remove an IUD if a patient tests positive for either an STI or PID?
Not routinely.
Okay. So you would treat through it?
Treat through it.
Okay. And then last question, this provider has heard conflicting recommendations about the proper way to collect rectal swabs for chlamydia. Do you know what the proper collection strategy is?
Yeah. So all it is, and in your slides there should be like a little flyer, an example of a flyer on how patients can self-do it. But if we think about it from providers as an anatomical collection guide, you want to insert the tip of the aptima swab or the Dacron swab, whatever you have, into the anal canal. And so max probably 5 centimeters of anal epithelium before you get to rectal epithelium. Remember, it's anal epithelium, you got your dentate line, and then it goes into the rectal epithelium. You want to try and get at least the cotton swab in a little further, do a spin, come out. It's really going to be the rectal mucosa, but the bacteria is sort of everywhere, and so as long as you can get past the rectal, like actually the swab into the anal sphincter, you are likely going to get an adequate sample to run.
And if patients are self-collecting, do you have them collect 2 swabs?
Yes. Remember, you send them separately, just make sure that they're labeled, but if someone is self-collecting, they could do it self-select, collect in their throat, in their vagina, and their rectum. You just need to label the samples.
Great. Excellent. Okay, we are going to take a 10-minute break. If people have other questions, please put them into the chat, and we'll try to incorporate them into our panel. And we will regroup at 9:45 for the next talk.